All right. Hello, everyone. My name's Creighton Kellogg. I'm a second year internal medicine resident at Atrium Health Carolinas Medical Center in Charlotte, North Carolina. I'm excited to be a part of this ACOI student lecture series where we're giving certain talks on certain aspects of intern year that we would hope to have you guys kind of progress through and be prepared for intern year. So, my specific lecture today is on intern level workflow and efficiency. A couple slides for you guys, just kind of help you progress as an intern, going from medical student to intern, as well as some topics that you can use to go from intern to second year as well. So the first title I have is How to Pre-Round with Intention. So pre-rounding is something that you'll do each and every day on your established patients. This can get burdensome very easily, especially if you have, upwards of 8 to 10 patients each day. But having a systematic process in place will help you stay calm, have less anxiety about your daily activities, and making sure you take care of your patients to the best of your ability. So the first thing that you'll do is when you come in, I know each program's different, but for my program, I usually get sign out from the night team on overnight events. Usually, overnight events don't happen too often for a majority of patients, but you do want to make sure you don't miss any acute events that happened overnight to your patients. And then finally, steps 2 through 7 are on your own before you go see each patient. So number two overall is you want to look at the vital signs. That is both current set of vital signs as well as those throughout the night. You want to make sure you're not missing a random fever that happened, if someone was tachycardic overnight, or if someone needed an increased oxygen requirement. I've had a lot of patients will have certain vitals throughout the night, and then in the morning they're normal. You want to make sure you're not missing those overall. Next step after you look at the vitals is looking at any new results. So basically labs and imaging, making sure you know the pertinent positives, looking at trends that happened over the last couple of days, and then all imaging results. And I do encourage you as an intern to actually look at your imaging rather than just reading the results from the radiologist. This helps practice over time and does make you a more efficient senior resident when you move forward. Steps number 4 and 5 are, usually unique to certain patient populations, so you may not be doing these steps. Number 4 is ins and outs, if they're applicable. You want to make sure you're having accurate ins and outs for people with heart failure exacerbations or with GI losses, and making sure you're keeping up to those. And then the next one is telemetry, or otherwise continuous cardiac monitoring. Before you go see the patient, whether you can do that at your own computer or whether you have to go to the nurse's station and look at the telemetry, making sure you look at everyone's heart rates, if they're making sure they're not having AFib, or heart block or anything like that. You just want to make sure you're not missing abnormal heart rates and heart rhythms throughout the night. Number 6, medications, just being familiar with what all of your patients are on, just in case they have questions when you go see them. And then number 7, the plan. This doesn't have to be formal, but just having a general idea and gist of what you're going to do for that day for that patient. A lot of patients will ask what they expect to happen that day. So going in with some sort of idea, like changing medications or going for a procedure or going for a certain imaging study, has them feel more reassured, and then, has you, have a good repertoire with your patients as well. The plan can always change after rounds, and you can always go back and update the patient. But this is something that you want to have a general idea of before you go to the patient, rather than go seeing them. They ask what you're going to do for the day, and you're not sure. So make sure you have a plan in place before you go to the patients. And when you do all of these steps for each of your patients, you should be spending no more than 5 minutes on each patient doing this. Then you're ready to go see your entire list on the floors. Next topic I want to talk about is presenting like an intern. I'm going to spend a little bit less time on this topic just because this is something that you guys have been working on as medical students. So again, just kind of a few reminders. So for new patients that you're admitting from the emergency room into the hospital, or if you're downgrading someone from the ICU back to the regular floors. Again, mentioning your subjective, mentioning the past medical history in your one-liner. So Mr. S is a 49-year-old male with past medical history of XYZ. and then mentioning the chief complaint, or presenting today with chest pain. And then after that, you proceed into your HPI, and then never forget a social history as well. Once you do your subjective portion, you want to present a focus objective. Number one, vital signs. Those are also vital signs upon presentation to the ER, their trends overnight or however long they've been in the ER, and then the current set of vital signs. Are things worsening? Did they come in looking terrible and now they're looking a little better? So just getting an idea of what happened vitals wise. Number two, physical exam. Number three, pertinent positive labs. So this is something that I do believe interns work on throughout the year and try to have a head start in July and August when you're a fresh intern. In this part of the presentation does make you look better and does allow you to progress easier. So pertinent positive labs. You do not have to report every normal lab that you find on a workup, but there are some pertinent negatives if they are applicable. If someone's presenting with chest pain and their troponin is negative, that is a negative that you do want to report. Someone's having abdominal pain and their urinalysis is negative for UTI, that's something that you want to report as well. So pertinent negatives if they're applicable, but otherwise you don't have to report every normal lab. And then number four, you want to do all imaging studies, whether that they're normal or not. All X-rays, all CT scans, MRI scans, ultrasound that was done in the ER, or if they're, like I said, coming out of the ICU back down to the floor, reporting all the imaging studies. Um, so you want to make sure you do all that as well. Next, for your assessment plan, you guys know this, acute problems in order of importance, and then your specific plan for each problem before you move on to the next assessment or diagnosis. And then if you're not going to deal with chronic problems, I would still list them. Just mention like patient has BPH, continuing, this medicine to help them urinate. We're not doing anything actively for this, but just listing them chronically in order. And those are for new patients. For established patients, you had them for a couple days, you're attending those them for the last couple days, everyone's aware about them. So these are often less formal presentations, but you want to do a similar presentation to like the above. No need to give the entire background, right? Unless there's a new member of the team that they're not familiar with the patient, you can give a one or two liner before you proceed. Um, the thing with established patients as compared to new patients, you have overnight events, right? So mentioning those before anything else. So what I like to do personally is Mr. Smith had no acute events overnight. Today I saw him at bedside and blah, 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 going into your HPI. So that's how I do established patients, making sure you mention the overnight events. All right, next, writing efficient notes. Again, this is also something that you guys have done as medical students, but you want to improve upon as you are an intern, and then that's something you also want to improve on as you become a second and third year resident. So the HPI or the subjective portion should be concise and to the point. Personally, I'm going to give you guys tips on what I personally do as I've progressed throughout residency. And, usually I write 5 to 8 sentences for a presenting problem. And then when patients have been here for a couple days, usually my subjective is a little bit shorter, but still has enough information that consultants can read and understand what's going on, but also not too burdensome and not too long. So that's how I personally do it. I personally do several small paragraphs, especially in my H and Ps for new patients. I separate problems. And, if someone's coming in with basically chest pain and right ankle pain, again, two very separate, very different problems. I'll have a big paragraph for the chest pain, then I'll have another paragraph for the right ankle pain. So it makes sense in my mind to do it like that. It makes it much easier to read. It makes it look better. So I separate each problem in my H&P with each problem having a specific paragraph. I'll do a separate line for review systems, and then I'll also do another little area for the social history. Again, these are options. This is what I personally do, so just trying to give some tips to what I have found helpful for me. So feel free to take this idea from me and tweak it to your liking. Objective. So in your notes, at least for me, at my hospital, we have auto-populated notes that bring in a lot of objective data. Sometimes imaging studies take off a lot of space. You want to take those out and maybe just list the imaging study that was done and the review or the recommendation by the radiologist. So just trying to delete burdensome and make the objective portion as nice and concise as possible to make it easier to read is something that I do recommend doing. Again, the assessment plan, again, concise is key. The longer the assessment plans, the harder it is to read and the harder it is to grasp what's going on. You want more than one or two lines for each problem, but having around maybe five bullet points that argue for your diagnosis or basically defend your point of why this patient has this certain diagnosis, just makes it a lot easier to read and much more concise. Usually, my last bullet can be a differential diagnosis. So if you list chest pain, and if you list the vitals, the labs, and the imaging studies, that last differential, you say, not sure what the etiology of this right now is. Could be ACS, could be a pulmonary embolism, could be musculoskeletal. Here's my thought process. Here's my reasoning. Again, that's just something I personally do, and it makes it much more easier to kind of remember as you move in the next couple of days for a patient's admission. And again, the plan should be and then we go down to the plan. So the plan should be a list, not a full sentence. So instead of saying, we'll admit patient to get a, formal echocardiogram, just say, dot TTE. Next line, chest x-ray. Next line, watch ins and outs. Rather than we plan on doing this, it just makes it easier to read when you just list rather than having full sentences. So less words, the better in the plan portion, but the assessment portion has full sentences, if that makes sense. And again, overall, in both H&Ps, discharge summaries, progress notes, be careful with abbreviations. Um, some are really easy to use, like COPD and OSA, but others make it a little bit more harder to read. Last thing you want to do is use too much abbreviations where people actually have to look up what they mean. So if they're very commonly used, it's okay to use them, but if not, I would avoid abbreviations if you can. Next, this is something I want to spend a little bit more time on. As you know, personally, I did not do this as much as a medical student, and had to learn in my first couple months of being an intern. But it's how to give safe, anticipatory sign out to the night team. So here at my program, we have one night team that covers now six, medicine teams that are on the floor. So it's one intern watching around 60 to 70 patients. So that's a lot of information to keep track of. So when you give sign out to these, the night team, you want to keep it as concise and to the point as possible. It makes it easier from them. And then when you do nights, you'll actually be on the receiving end of this, and you'll actually realize that it's actually easier to get less information, but the most pertinent information first. So here at my program, what we do is we give a clinical state and then a one-liner, and then we give a bunch of outcomes and contingencies, basically. So next, you want to give the status. So is the patient stable? Are they a watcher? So they're kind of a tenuous situation, pretty sick, or if they are unstable. First and foremost, you should probably never be signing out an unstable patient anyway. So really, that one's hardly used ever. So really stable or watcher. Next, we have code status. Again, this is personal to my own program, but I do feel like it is important. So just making sure everyone's on the same page if they're full code or if they are just do not resuscitate but are able to be intubated, if they are completely do not resuscitate, do not intubate, or if they are comfort care and that we don't have to do anything workup wise for those patients. Next, you want to give a one-liner. So, very limited past medical history. Do not list their whole history, just list the pertinent stuff as to why they're in the hospital. Then you list their chief diagnosis and then list their current plan. So, I'll give you an example. So, Mr. S is a stable, full code, 48-year-old gentleman. He has a past medical history of type 2 diabetes as well as hypertension. He's here for lower extremity cellulitis on IV antibiotics. That's it. So you want to keep it as concise as possible and not bog the night team down with extra information that's not going to help them overnight. So I hope that example was helpful. Some patients are very complicated and maybe their sign out takes a little bit longer, and that's okay. But for some simple patients, and some simple problems, less is more, less is better. Number three, this is the most important part, is you want to prepare for possible outcomes and situations and give contingency planning. Try and think, obviously it's hard to predict the future, but when you admit these patients, you are going to know them better than the night team. So you can probably predict what might happen in the night better than they can. Okay. So if someone might become hypotensive, tell the night team what to do for hypotension. If someone's coming in with a cardiac condition or if they're coming in with chest pain, give them a workup of what to do if they have chest pain again. Shortness of breath, signs of infection, unstable vitals, anything that you can think of that could happen overnight, trying your best to set up the night team for success as best as possible. It is impossible to predict everything that might happen, but trying your best makes it much easier on the night team. So if I use my previous example, if someone's coming in with cellulitis, but they are stable, you can say, hey, they're hanging out, they're doing well, getting IV antibiotics, but if they are hypotensive, think of septic shock. I want you to get blood cultures. I want you to do a repeat infectious workup, get a lactate, and have a low threshold to consult ICU. So that's one example of a contingency for something that I could predict that happens for a certain patient. Okay. And then to also limiting nighttime pages and messages, I like to order safe PRNs. So pain medications like Tylenol, maybe some low dose help with patients, aids like melatonin, antiemetics or any nausea or vomiting, medicines that can help patients. So just limiting, messages overnight can also help as well. My last topic I'm going to briefly touch on is how to call a consult. Personally, at my program, we use a messaging system that we can text everyone. Some programs might have to, pick up a phone and call them. But overall, you want to keep your consult, as brief and concise as possible, but have as much pertinent information as you can. So you want to give the one-liner to the patient. You guys should already know how to do that with the past medical history, for that respective field. If you're consulting cardiology, feel free to list their entire cardiac history. If you're a cardiac patient but you're consulting infectious disease, maybe you can limit that a little bit. Provide why they are in the hospital. Usually, this is the chief complaint when you are consulting someone in that field, or if it is a separate issue. If you're, consulting cardiology on someone with lower extremity cellulitis, just mention, hey, they're here for lower extremity cellulitis, but I'm consulting you for this. Just kind of make it clear of why they're in the hospital. Most important thing is having a specific question. You don't want to just message a consult or call them just to have them on board. You want to have a specific task or question to them that can help. It needs to be straightforward, and you're okay to say, I would appreciate your help with X, Y, and Z, or I would appreciate if you were to come evaluate this patient for, X, Y, and Z. So it's okay to say that and ask for help. That's what they are there for, and that's what basically you are doing for a consultant. Just making sure you have a specific reason and a specific question why you're consulting them is the best way to proceed about a consult. And then in the end, just thank them and always provide maybe like a phone number for them to call you back, etc. So that's briefly how to, call a consult. And the more you do this and the more consultants you work with, the more appreciative they are and the more likely they are to help you if you're, if you're specific, if you're precise, and it just helps both parties all involved. So that's the end of my presentation. I hope you guys got a lot of helpful information from this. If you guys have any other questions about this presentation or intern year in general, feel free to email me. This is my personal email. It's creighton97@gmail.com. But yeah, congratulations everyone for recently matching. I wish you all the best of luck in your intern year, and hopefully you guys become, excellent seniors, and eventually residency goes well for all of you. So thank you so much. Take care.